I want to spend the next 15 minutes or so just covering three areas. One, to give an oversight, overview and context of the position that we're now in following the creation of NHS England from the 1st of April, this revised role for the Department of Health as part of that. I want to touch upon the initiatives stroke projects that are now in place as a result of Dr. Murison's report, Fighting Fit, on accessing mental health for service personnel and veterans. I'll be focusing on the latter, veterans. And third, just to flag up some challenges that I see for all of us going forward, which hopefully will help spark some conversations during the rest of the day for you. So that's where we're going to go with that. So the first part, what's the context? Where are we with this now as from the 1st of April? The health and care system within England has gone through a small change over the last 6 months with the creation of NHS England. So the way in which services are delivered to the people at the front end, those accessing those systems, should actually see no difference, but the way in which those systems are provided have actually changed quite a bit. You can see for yourself that the areas that the Secretary of State has by way of responsibility, the fact that he provides a strategic direction, and that it's around system stewardship of the system. Now, some of that might play out rather strangely in that ministers still, even now, are very much at the forefront of issues around delivery of NHS services. We hardly go a day without seeing issues around A&Es, etc., and funding. But the responsibility lies with NHS England. I think it's very important that we remember that as we go forward, as we drill down through the layers into how services are delivered for the Armed Forces community. How does this play out for this community? The NHS mandate and the Armed Forces Covenant. The mandate that the Department of Health, that the government have given to NHS England, has just one line in relation to armed forces, and it's upholding the government's obligation under the Armed Forces Covenant. Now, there's plenty of discussion and debate about whether that should have then gone on to list all the things that we would like done by NHS England. I'm actually quite fond of this one line, because it seems to me that under the Covenant you can hang any number of armed forces related issues underneath it. So I think this actually having that one line is perhaps better rather than a prescriptive list. The Armed Forces Covenant, I'm guessing that you'll all be familiar with this. The key words there are around no disadvantage. For the vast majority of the Armed Forces community, for particularly veterans, particularly families, they will access NHS services in the same way as anybody else. Their needs will be the same as anybody else. But it's ensuring that no disadvantage. It's ensuring that somebody who is based in the east of England now, a family or a veteran in the east of England now, actually family, and then move down to the southwest, for example, actually aren't disadvantaged as that move in accessing services locally. The Covenant does highlight an area where it does create difficulties for those of us within the NHS around special consideration. What does special consideration mean? How do we marry that against the requirements of the NHS Constitution, about the requirements of equality, about the requirements of ensuring that people are dealt with in relation to clinical need? There's a challenge there for all of us in how we actually meet that. There's an issue around veterans and priority treatment, an issue that sometimes gets misinterpreted. It's not about jumping queues, it's not about putting somebody up to the top of the list at the expense of anybody else. Quite often the words subject to the clinical needs of others gets missed off that particular area. So there's an issue around priority treatment. What does it actually mean for veterans? I personally think it's not so much about priority treatment. I think it's about the right treatment, right place, right time. If you get all those three in the right place, why would somebody need any special measures? And that goes for veterans, goes for anybody else. This isn't a brilliant slide, probably a little bit busy and it doesn't come across very clearly on the screen. But really, this is just to just give some a picture, if you like, of where all of this now sits. I shall walk away just for the sheer hell of it. So on the outer ring here, we have the Department of Health, we have ministers. On the right-hand side, we have other government departments. So in our instance, in particular, the Ministry of Defence. In the top left-hand corner there, the two purple dots, if you can see it, that's got CCGs in that and the NHS Commissioning Board, as was, now NHS England. Down towards the bottom left-hand there, we've got Public Health England. So you can see where we've got people and communities in the middle, you could quite easily just rebrand that and say Armed Forces personnel serving, families, veterans and reservists, because any one of them would sit in with that graphic quite easily. So a very busy slide, but then that just represents a very busy situation that we now have. We have a number of agencies that are responsible for providing bits of that jigsaw and providing those services. So question, how do we bring those together? I'll go back to that first slide around stewardship. How do we in the DH work with NHS England to provide that? How do DH, NHS England work with the MOD to provide it? How does DH, NHS England, MOD and service charities provide it? And so it goes on. Drilling down a little bit further, how do we take that big circle and then start to bring it down into where we are now and where many of you out in front today are actually involved in delivering services. Along the left-hand side of that picture, it attempts to demonstrate the role of NHS England, if I can say NHS England Central, and their responsibility in commissioning secondary care for serving armed forces, members of the armed forces, and families who are registered with Defence Medical Services. On the right-hand side, we're talking about families, generally. We're talking about veterans, and we're talking about reservists when they're not deployed. So this right-hand side, I would suggest, is the area where many of you need to focus. It's about how do you work with CCGs? How do you work with armed forces charities? How do you work within the NHS system so that CCGs and other commissioners within the process are sighted on the needs of that particular cohort? I've come across over the last 6 months, and perhaps not surprisingly, because NHS England, this system has only been in place really since the 1st of April, some confusion within with NHS colleagues as to which side of that divide they're on. I would suggest that actually it's the right-hand side that you're really, really looking to focus on. Having set that picture about the new world in which we're sitting and where we're trying to take that and the working relationships within it, this conference is about mental health and it's about the services that are in place in relation to mental health. Just out of curiosity, hands up all of those who have read Dr. Murison's Fighting Fit report. Okay. And those that have put their hands up, I recognise most of you, which is probably a bad thing or a good thing, I don't know, but that's NHS colleagues, etc. It's a very slim report, so Google, Yahoo, Bing or whatever it is you wish to do afterwards and go and have a look. Within that report it identifies a number of issues to be addressed with regard to accessing mental health services for serving personnel and for veterans. It does not talk about families within that report. I've concentrated here on the services we put in place for veterans. That was led at the centre from the Department of Health, because that's the position we were in 2 years ago, 3 years ago when that report was published. Clearly things have moved on, so that the names in bold are where those particular projects will or already in place. We have 10 NHS mental health teams. We have an excellent Veterans Mental Health team in Colchester with Diane Palmer and team, doing some brilliant work in Colchester. Challenge, how do we get that across the rest of East of England, working with Enable East and colleagues around here. But we have another 9 around the country, and we're looking at how they've operated over the last couple of years. We need to draw together the really good work that's been done, identify the other work that maybe has not been so successful, so that we can come up with a model going forward to 2015 and beyond that's fit for purpose across the whole of England. The Big White Wall is an online counselling service. When we commissioned that, and unusually that's a DH commissioned piece of work through till March 2015, we were keen to include families within that. So families, veterans, and indeed the MOD commissioned the Armed Forces personnel, that serving Armed Forces personnel part of that is in place and is going well. Again, a quick Google of Big White Wall will give you some more detail what they do and how they do it. We commissioned and worked in partnership with Combat Stress and Rethink the 24-hour Veterans Mental Health Helpline. So the start-up costs and the cost of that for the first 2 years, DH funded, working very well, I'd like to think, with Combat Stress. That's now funded through the LIBOR funds, and I'm sure Peter Paul will touch upon that more in his chat. E-learning package with RCGP, again, if you go onto the RCGP website, you'll find that e-learning package. It's almost an entry-level description of the needs of the Armed Forces community. You don't have to be a member of the RCGP to access it, you just register as you would with many other sites. Veterans Information Service, we've put this in place so that with the MOD and Service Personnel Veterans Agency, so that those who discharge will, about a year after discharge, receive an email letter saying, hope things are going well, if not, signposting them to a number of agencies may be able to help, including Big White Wall, including Combat Stress, including NHS Veterans Mental Health teams. The ambition is to join that up with the Royal British Legion and the new services that they're putting in place, and we hope to have that in place by the end of the year. The last bit there, the National Veterans Mental Health Network, really that's in place to try and draw together all this work that's being done and to try and make some sort of sense of it, if you like. As I said earlier on, pick out the good pieces of work on that, the good experience, the good practice, and looking to deliver that across the wider area. 4 minutes is more than enough time. I'm actually into my last couple of slides. There's, in addition to the Murison Fighting Fits, many of you would have noticed that there's other projects around. Some of these, many of these are funded through LIBOR funding. I've already touched upon that with the 24-hour mental health helpline. Combat Stress is also commissioned for specialist PTSD. I will not spoil Peter's thunder on that one. I'm sure he will speak about that. But really the point of this slide and the next is really just to flag up that these are just some of the projects that are being funded through the LIBOR fine. So this is a £35 million fine on, I think it was Barclays, around interest rate fixing. The government decided, rather than just putting that back into the Treasury, it'd be provided for Armed Forces community projects. Covers any number of things, but an awful lot around health and well-being, and particularly mental health. So I wanted to just flag up, these are some. There are plenty of others out there. So where does that leave us? Where does that take us? I think some challenges around this work, and as I mentioned earlier on, perhaps some areas for discussion during the course of the day. Well, funding. The work that we've put in place, the 7 and a bit million that I've had sitting in my back pocket to pay for many of these things, runs out at the end of March 2015. Many of the services that we mentioned there actually are services that in future will need to be provided by CCGs. How does that work? How do local providers engage with CCGs to ensure that that work continues to be commissioned as from the 1st of April 2015? Sustain and embed. It's fine for, I'm around, people have heard my name, great. I'm not going to be around forever. There's any number of people that I recognise in this room really passionate about driving this agenda forward, and we've been helped by the high profile from Afghanistan and Iraq, political interest, media interest. That's going to change. The troops come back from Afghanistan next year. perhaps will not be as high on that media level of attention. So how do we make sure that the services we're putting in place today, the services that you guys are commissioning today, actually continue beyond our own existence doing this piece of work? And then there's coordination. Flagging up the LIBOR projects there, you know, all very, very good projects, but how do they work? How does that work? How does that link in with the services that are being provided by the NHS? How are the NHS services, the Veterans Mental Health teams, how are they linking in with third sector, with LIBOR-funded services? How are they linking in with the other parts of the NHS? So I think actually to get through to that, there's something around coordination and real working in partnership. So I'd like to leave you with just those three thoughts, and hopefully that will help tease some of the discussions, etc., that you might have during the rest of the day. And by my reckoning, that's about 20 seconds left.
Fantastic.
Thank you very much. Cheers.